So the title of my presentation is Preventing Excessive Weight Gain During Pregnancy Through Dietary and Lifestyle Counseling. The incidence of obesity in the U.S. has reached epidemic proportions. The prevalence of obesity is increasing in both sexes, age groups, and racial groups among other educational levels. According to the article, adults 20 to 74 have increased from 15% to 33% in a 2004 survey. Today, 39% of adults over the age of 18 are overweight. 40% of those are women. The worldwide prevalence of obesity more than doubled between 1980 and 2014. Associated with an increase in obesity is an increase in several other health conditions. In women of reproductive age, there is an increased rate of preeclampsia and postoperative complications, which is a major concern in pregnancy. The Institute of Medicine, IOM, recommends that underweight women gain about 35 to 45 pounds during pregnancy. Normal weight gain women would gain 25 through 35, and so on for overweight and obese women. So pretty much the smaller you are, you should be gaining more weight. Weight gain within these guidelines has been associated with healthy fetal and maternal outcomes. Unfortunately, the prevalence of excessive gestational weight gain is increasing. The purpose of the study is to examine an intervention aimed at reducing excessive gestational weight gain. The study hypothesized that an organized, consistent program of dietary and lifestyle counseling would prevent excessive gestational weight gain. A randomized controlled trial was designed to compare a program of intensive counseling regarding diet and lifestyle during pregnancy with routine prenatal care. The intervention aspect provided educational feedback about weight gain, appropriate exercise in pregnancy, and pregnancy-specific dietary counseling. 57 women, which were part of the intensive counseling group, and 43 were part of the routine care group. There was an inclusion and exclusion criteria. First, a couple things for the inclusion criteria included prenatal care being established at 6 through 16 weeks at gestation and 18 to 49 years of age, as well as a singleton pregnancy. For the exclusion criteria, a couple things were that prenatal care established at more than 16 weeks of gestation, multiple pregnancies, and a BMI higher than 40. The study was explained in full to each participant. One consent was given, participants stratified based on their BMI. 3 categories were as follows based on the reported BMI. Group 1 was broken into underweight and normal weight participants, Group 2 overweight participants, Group 3 obese participants. Once they were placed in their groups, patients were assigned randomly to either the control group who received routine prenatal care for the remainder of the pregnancy, or to the intervention group who received the standardized protocol of dietary lifestyle counseling. So for the control group, they received a routine prenatal care included physical and examination and history. The only counseling on diet and exercise during pregnancy received was from a standard prenatal booklet. At appointments, the participant's weight was measured. The healthcare provider did not counsel on any changes in the diet or lifestyle. For the intervention group, they underwent a complete history and physical examination, much more in depth. They met with a registered dietitian to receive a session that included information on pregnancy-specific dietary and lifestyle choices, and were told to engage in moderate to intense exercises. Their appointment was a little bit different. The care provider would take their weight and tell them whether they were at an appropriate level or not. They would either get praised or they would work a little bit harder on the regimen that they were currently doing. Both groups had their weight recorded shortly before the delivery. Total weight gain and the BMI change from the pre-pregnancy to just before the delivery were examined and compared between the study and control groups to deduce the efficacy of the intervention. The sample size was chosen based on several criteria. 30% of women in the routine group would gain within the IOMA guideline, and that an increase of 25% of women in the intensive counseling group gaining within the IOMA guidelines would be clinically significant. An 80% power and an alpha of 0.05 was used, in which it required 61 participants in each treatment to achieve statistical significance. Potential differences between the two groups were analyzed using t-tests. Odd ratios and 95% confidence intervals were estimated for the relationship between gestational weight gain category and treatment group using multivariable logistic regression models. A p-value of less than 0.05 was used to define statistical significance. No statistical significant difference was detected in demographic composition between the intensive counseling group and the routine care group. The primary outcome was the rate of adherence to the IOMA guidelines between the study groups. Participants in the intensive counseling group gained significantly less weight compared to those in the routine group. Even though the intensive group gained less weight, there was still no significance in the rate of adherence in those guidelines between groups, as well as no significant difference in the adherence across BMI groups. In conclusion, the intensive counseling during pregnancy did reduce weight gain in comparison with the control population receiving routine prenatal care, but it did not result in a significant increase in adherence to IOMA guidelines. Okay, so some of the pros for this study included the random assignment. Participants were allocated in two different groups, the control group and the intervention group. Then they were placed in such a way that the probability of appearing in either group was equal. They did a very confidential manner. They did it very computerized. Next would be the clinical significance was selected at the beginning of the study. It was mentioned that their point of value was going to be 0.05. That was not changed, although as we saw that there was no significance relevant to that area of significance. Next, there were a significant amount of variables that were manipulated when running the square of means as well as the different t-tests. We were able to see from the different tables that they tried to manipulate whether it was their post-delivery method or a couple things that were doing before their pregnancy that went on past the selected variables. So they did choose secondary variables. Next, the study can be replicated today in a variety of ways. It becomes very simple. One group receives the intervention of the dietary and exercise consultation by a dietitian, while the other group does not. Although all the participants knew and gave consents to be part of the study, participants did not necessarily know what group they were going to be part of. For example, would they be exercising more, eating less? So even though they were explained this, they weren't exactly knowingly knowing what group they were going to be part of the study. So now that we're able to replicate the study, the results can be generalized. Although there was no clinical significance found, weight loss was achieved by the intervention that was provided could result in a decrease in antepartum, antepartum, and postpartum complications. So the intervention may have also reduced pregnancy weight retention and obesity in the non-pregnant state, which could also reduce the overall obesity-related diseases such as diabetes and cardiovascular disease. Okay, so now a couple cons for the study. First was that the researchers were unable to exclude a potential Hawthorne effect. Participants were selected for a study in which they were counseled on weight gain, nutrition, and exercise. They were told this when they were given consent. So in this case, once people are told that there is that effect, that they are more likely to pay attention to the specific factors in their life and modify those behaviors accordingly to perhaps do better on the study or believe that they are doing better to find out what the study is trying to do at the end. So although this could be viewed as a positive effect that overall the universal counseling could bring out in all the patients, whether they were in the intervention group or they were in the control group, this did affect the research study to show that significance between the two groups. The next con of the study would be the number of participants used for the study. At the beginning of the study, a total of 144 participants were used, but with all the inclusion specifics and the exclusion, they were unable to be part, so they did need to be dropped, whether that was at the beginning or towards the middle of the study. So in order for the data to be significant, a total of 61 participants needed to show some significance from the already 100. So that could have been effect. So perhaps a larger data set could have shown significance at the end. The next con would be a volunteer bias. The research did mention this was a big drawback to the article because they believed that people who are healthier in general tend to volunteer for research studies. In this case, people were more likely to eat better. That was part of their lifestyle. So we weren't able to necessarily see the people with a higher BMI, what their data would actually look like. And finally, the validity of consistent content of counseling. For the intervention group, that was very hard to control because the counseling they received actually looked a little bit different, specifically each time they visit the clinic. Some participants needed help on exercising more while others needed to eat less. So the advice that was given to them during each of these visits was very different. So there was not a consistency. So that may have also injured the validity of the study.